These days, the Internet contains eye cancer reference books, images, and even pathology analysis of ocular tumors and orbital diseases. So today I plan to share with you new, interesting, and essential concepts in ophthalmic oncology. Note that this work will include my work, others' work, multi-center international cooperative studies, and analysis of all. Most importantly, this presentation was created to give you the tools to become better ophthalmologists and eye cancer specialists. Now let's go a little farther back, even behind the eye, to orbital tumors, current concepts. Today we will discuss the Danish Multicenter International Ocular Adnexal Lymphoma Registry. Then explore immunotherapy for orbital melanoma, squamous carcinoma, and basal cell carcinoma. Lastly, we will look at select orbital innovations. Ocular adnexal lymphoma is the most common orbital malignancy. Also called OAL, data was aggregated within a multicenter international registry and used to answer certain questions. 12 centers from 5 countries participated. Stefan Herein organized the registry. Let's take a look at the primary conclusions of the Danish OAL registry. Histopathologic subtype was found to be more important than the location-dependent AJCC stage to predict mortality. Local control and systemic outcomes were better for marginal, also called malt lymphomas, which were better than follicular, which in turn were better than large B and mantle cell. Orbital radiation therapy was associated with less subsequent systemic disease for certain subtypes. This registry provided statistically significant OAL data on all histopathologic forms and tumor locations around and behind the eye. Lastly, follicular OAL was more common in females, while the mantle cell subtype was more common in males. Let's explore immunotherapy for orbital tumors. It's reasonable to say that systemic immunotherapy is revolutionizing cancer care. This is also true for orbital tumors. I'm pleased to share with you this paper on checkpoint inhibition immunotherapy for advanced local and systemic conjunctival melanoma. This case series came from the New York Eye Cancer Center as well as the New York University Comprehensive Cancer Center under Dr. Pavlik. In this small series, we saw both complete remissions and extensive tumor shrinkage in most patients. These images show a patient with diffuse multifocal conjunctival melanoma. I offered him exenteration, and he refused. He did, however, consent to systemic immunotherapy, and after 3 years and going, he has no evidence of either recurrent or residual disease. Here is another patient with sequential CT scans. On the top left, you see 2 metastatic foci. Over the subsequent every 6-month CT scans, the one lesion disappears and the other one shrinks, but does persist as a small lesion. 2.5 years after immunotherapy, the patient is controlled. I've often heard that one swallow doesn't make a spring. Well, that's true in checkpoint inhibitor therapy for conjunctival melanoma. In 2018, Beta Ismaili published on programmed cell death 1 inhibitors for patients with conjunctival melanoma and has another paper in the OPRS journal Impress on checkpoint inhibitor therapy. Clearly, multiple centers have found the same thing, that conjunctival melanoma does respond to immunotherapy. Clearly, immunotherapy is going to be used for other orbital tumors. There exist publications on the use of hedgehog inhibitors for orbital basal cell carcinoma, as well as Libtayo for orbital squamous cell carcinoma. Current indications for treatment of orbital squamous are for the treatment of patients with locally advanced or metastatic squamous cell carcinoma who are not candidates for curative surgery or curative radiation. These treatments are not without side effects, and they must be discussed with the patient prior to starting therapy. First, we see a patient with locally advanced periocular basal cell carcinoma of the right upper eyelid, brow, and anterior orbit. This tumor would be staged in an AJCC T4A N0M0 tumor. This patient denied exenteration surgery and was treated with neoadjuvant immunotherapy for 18 months to almost complete resolution, followed by eye-sparing surgery. The last two images are at 6 months after surgery. The second case, seen in the left photograph, reveals a patient with locally advanced periocular basal cell carcinoma of the right lower eyelid, medial canthus, and cheek. It would be staged in AJCC T4A N0M0. He denied exenteration surgery and was treated with neoadjuvant vismodegib, allowing for eye-sparing surgery. Surgical excision of the two medial residual tumors was accomplished with negative margins, yielding the right photograph at 11 months. Note the resolution of his ectropion, as well as the loss of eyelashes and brow hair. Here I've reproduced Table 1 from this paper, which appeared in 2019 in the British Journal of Ophthalmology. Its subject was immunotherapy of locally advanced periocular basal cell carcinoma. Two things I picked up for this lecture include a 63% complete response rate, as well as the mention of side effects of therapy. So let's segue to other orbital innovations, which include orbital brachytherapy and my small incision aspiration cutter biopsy technique. Brachytherapy is Greek for close. Close being that the radiation is put into the tissue or on the tissue to be treated, as opposed to teletherapy, which is from afar. On the top left, you see the brachytherapy isodose distribution concentrated to the orbit. In fact, the center of the orbit gets the highest dose, and the dose drops off rather quickly as it gets to the periphery of the orbit, the eyelids, and eyebrow. In contrast, on the right, you see an external beam radiation therapy isodose. Here we have an entry dose that goes through the eyelids and eyebrow into the orbit, and an exit dose which reaches into the anterior brain. I'm not saying that it's easier to do brachytherapy. In fact, you see that it's a surgical procedure where catheters are placed in the orbit and there is remote afterloading of radiation over a period of days. However, the outcomes are very starkly different. On the top, you see a patient who's had external beam radiation therapy with a sunken orbit, a loss of eyebrow and eyelashes, and a dry socket. On the bottom, a similar patient who was treated with brachytherapy with relative preservation of the eyebrow, eyelashes, and a better cosmetic look. In addition, the amount of radiation delivered to the patient on the bottom was actually larger to the diseased orbital tissue. There's an additional technique used for select tumors called brachytherapy boost. That's where you place the radiotherapy applicators in a portion of the orbit, and that area of the orbit receives the high dose with an overlay of radiation to the entire orbit. As you can imagine, the area that is treated with both brachytherapy and external beam gets twice the dose. In review of the literature and my experience, brachytherapy has been used for residual orbital melanoma, retinoblastoma, adenoid cystic carcinoma, sebaceous carcinoma, basal cell carcinoma, and hemangiopericytoma. If you would like to read more about it, I wrote a survey article reviewing orbital radiation therapy in 2009. Lastly, I'd like to talk about FACT. I always thought that we should have a device that could go into an orbital tumor and both actively aspirate and cut tissue to retrieve a biopsy specimen. Such devices are used for breast biopsy, and I have, in a series, obtained both tissue and cells utilizing a 20-gauge aspiration cutter through a 3mm cutaneous or conjunctival incision. It has been my experience that FACT works best for metastatic orbital carcinomas. It does not work as well for lymphomas, which often require extensive immunopathology and even flow cytometry. However, for those cases where a patient can have a 3mm sutureless incision and obtain a biopsy and get back to work or back to their life as soon as possible, it is quite helpful. In summary, the Multicenter International Ocular Adnexal Lymphoma Registry found that tissue type was more predictive of survival than tumor location. They also noted that irradiation of the orbit was associated with less subsequent systemic disease, particularly for MALT and follicular lymphomas. Immunotherapy for advanced local and systemic conjunctival melanoma effectively reduced and controlled these tumors into small case series. They reduced the need for exenteration surgery, and new immunotherapies are on the horizon for squamous carcinoma and basal cell. Orbital brachytherapy can be used alone or together with external beam radiation therapy, called the brachytherapy boost technique, for orbital cancers. It was found to improve cosmesis compared to external beam radiation therapy alone, and it offered equivalent local control. Finger's aspiration cutter technique obtained both cells and tissue from orbital tumors utilizing a 20-gauge aspiration cutter through a 3mm incision. I suggested similar indications to fine needle aspiration biopsy, but this technique, unlike FNAB, yields both fragments of tissue and cells for immunohistochemical analysis. I want to take a moment to thank you for your attention, and to thank the Eye Cancer Foundation, who supported much of the research presented in this lecture, and for their committed support for international multicenter cooperation in ophthalmic oncology. Thank you and have a nice day.